afternoon. Can you hear me okay? I'm Donna Bliss. I am the moderator of this session and chair of the ICS Nursing Committee, and I would like to welcome you to a roundtable on fecal incontinence from bench to bedside. Here is my disclosure. We have 3 expert speakers on this topic. Dr. Massarat Zutshi from the Cleveland Clinic, who is going to talk to us about the principles and progress of cell-based therapies for fecal incontinence. Julia Herbert is a physiologist from the UK who's going to review the evidence for conservative behavioral management. And Dr. Holly Richter is going to discuss the role, evidence, and efficacy of surgical procedures. This roundtable is a little more casual than a general presentation. So the speakers have prepared a few slides to sort of stimulate some discussion. We will take questions after Massarat's talk, and then we'll have the final 2 speakers, and they will take questions together at the end. So I also want to invite you to attend the AGM, which, according to my schedule, occurs in this room. So if you would like to just sort of stay in the area after our roundtable, the AGM will take place in here.
I have no disclosures for this session. So the reason to bring this talk up is because there's so much interest in stem cells. And I feel that this theory of have stem cells will inject should go away. And we should kind of, at our level, kind of set some standards for stem cell therapy before it becomes a therapy that is not recognized. So here is some of our experience, some of the reviews of some papers, and my take on stem cell therapy. So what are stem cells? Stem cells occur in almost every tissue. There are different kinds of cells. In muscles, you have satellite cells. You have them in bone marrow, adipose-derived cells. They are also taken from Wharton's jelly and dental bud. And all these are being used in various therapies all over the world. The mode of action could be regeneration or the paracrine effect. So the older theory was that you inject stem cells, and then when you do so, these cells regenerate and create new tissue. The newer theories tell us that the cells act by a paracrine effect, and they affect the tissues around. So this is a busy slide, but just to tell you that the MSCs or any kind of stem cells have a lot of effect by various kinds of cytokines that they produce. They produce immunomodulation, they're anti-apoptotic, they promote angiogenesis, they have anti-scarring issues, and also chemoattraction. And the paracrine effect is the effect of these enzymes that cytokines that these cells produce on the local environment. And they stimulate the local environment to produce cells that are conducive to that local environment. So the MSCs that are popularly used these days are bone marrow derived. They give rise to cells of mesodermal origin, and they are commonly used in a lot of models of injury. They're immune privileged and are used from allogenic sources. The most common therapies are used in the heart, and they have some amount of success in heart failure and after an acute MI. And the reason for this is that there is inflammation at that time. So why do they work? And this is my pet peeve, is that don't inject cells because they have to work, but because they should work. So why should they work? They should work only when their signals of injury last. The stem cell should be able to reach the site of injury, and the cell should be in sufficient numbers to initiate and sustain a repair. So this is one of my fellows. He had this in 2008. He drew this picture of having an injury, and then you have the injured cells give out these cytokines, and the cytokines attracts MSCs. So the green that you see here are the stem cells. These are the cytokines, and this was from the site of injury. So it's only when these signals appear do cells go and do anything. So what do they do? So the cells have receptors on their surface. And these cytokines go and get attached to these receptors. And this is like a lock and key mechanism. And unless this occurs, you don't get these transcription factors that affect the local environment. So why do tissues not regenerate at the time of injury? We all know that you can injure the anal sphincter, and it will heal somewhat. And if it's a small injury, it will heal. But if it's a large injury, it may not heal. And you may not see the injury for over a long period of time. So this cytokine expression that does occur after any injury. However, there are not enough levels to sustain a repair. The acute injury in the anal sphincter is often not recognized. And when it is recognized, those cell signals have long gone. And finally, you have age-related factors that occur in the muscles that definitely add to this, and that's why you see all these symptoms so much later in life. So what can you do about it? How can you make the body believe that there's something going on there so that you can get stem cells there? So either you have to inject some cytokines there and trick the body into thinking that the cytokines are telling you that there's injury, or you have to use some kind of a low-grade injury to get cells to that area. So the cytokines that we have studied, and this comes again from the cardiac literature, is SDF1, which is stromal-derived factor 1, and its receptor is called CXCR4. And this is one of the most important cytokines in our body. If an animal is born without this factor, it does not survive. So it's very important for cell growth. The other factor that we looked at was MCP3. And it's called monocytic chemoattractant protein. That means it attracts monocytes to the site of injury. And this, we've looked at both these in the anal sphincter, and Margot Damasar has looked at in the urethral sphincter. And we know that both these cytokines are upregulated soon after an acute injury. And about 9 days or 10 days later, they start going down. And by 21 days, this is completely gone. And this was in an animal model. I'd love to do this in a human model and see if you have a vaginal tear and look at these cytokines and see in real time what happens. So we came up with this idea that a conditioning injury is needed. And we looked at different conditioning injuries and finally came up with electrical stimulation. And this is a poster downstairs. Electrical stimulation, when you looked at electrical stimulation, it works just like a low-grade injury and upregulates the same cytokines. So in the heart, they have used exercise. In the brain, they use hypoxia, anything to make the body believe that there's something going wrong there. So we used electrical stimulation, and we found that the stem cells go to this area wherever you stimulate, and they remain there for a period of time in order to effect a repair. So we used it in acute injury first, and when we found that it works as a stimulation. We then used it in a chronic injury. So we created a chronic injury and then used electrical stimulation to bring the stem cells to this area. And this is a work in progress. We need to look at this in a little more detail. So every model that has looked at for stem cells has been in an acute injury model. So these are the studies that looked at skeletal muscle. And all of them have shown that in an acute injury model, whether it is a cryo injury or it is a sphincter repair, these cells will go there and will create some effect. They will create some muscle, or nobody has shown that the cells stick around there, but they do have some effect. Similarly, and when they looked at the safety of this, only one study that looked at safety of skeletal muscles. And they found that there was no evidence of cell migration to the liver or lung. However, 2 transplanted rats developed an abnormal foci of growth. This was a benign tumor from the external sphincter, raising further safety questions. So therefore, I say before we go in and have stem cells and will implant theory, we should look into these safety factors. So the mesenchymal stem cells, there have been fewer studies. 2 of them were ours. These are other studies that looked at, and all these studies started around 2008 and looked at all acute injuries. We are currently looking at a chronic injury, but I'm not ready to show you some slides. We have very early results, which are very, very promising. And all of them show that the local injection of stem cells works. We looked at IV and IP and found that the cells just get lost in the lung and liver, so that anal sphincter is easy enough to inject cells into. These were this was a very interesting recent study. And what they did is they did a cryo injury, and they injected cells at the border of the injury into the lesion and away from the lesion. And what they found was whether they injected at the border or into the lesion after an acute injury, there was growth of muscle tissues. However, opposite to the lesion, that means that there was no injury, and into normal muscle, nothing happened. So this goes to tell you half cells will inject, will not work. These were 2 studies that we did, which looked at anal pressures, and found that after an acute injury, anal pressures do increase. So we started off using a smaller injury, and now we take off about 50% of the anal sphincter and still find evidence of regeneration. But again, it's an acute injury. So what is our goal? We want to find factors that will change how we look at fecal incontinence. The MSC therapy should last over time, or we should be able to tell people, you have to do this over so many periods of time, maybe every year, every 3 years, every 5 years. We have to find the right factor to cure neuropathic incontinence, because, or we have to show that if we inject stem cells, there is some neuropathic progression also. And so we are evaluating SDF1 plasmid with and without MSC in a chronic injury. And we are also using this in a model of Crohn's disease. So there was one human trial, and this was about 5 years ago. And they have recently published an abstract with current evaluation. So they took 10 women, and they did electrical stimulation of the anal canal, not into the muscle, for 21 days, and then injected autologous myoblasts. And they injected it under ultrasound control. And all the patients were improved. However, they never showed any increase in resting pressures. They did not show any increase in the ultrasound appearance of the external anal sphincter, which goes to tell you that, are we asking the right questions? Is this a placebo effect? So, we really, as a group, need to figure out what is it in a stem cell therapy that are we going to look at to say that this therapy works or does not work. Otherwise, you're going to have all these trials, especially industry-sponsored trials, which are going to change how we evaluate these patients, and I don't think we should let them dictate that. So is there a role for a neoanal sphincter? It's easy to create, and is there a neural control? So the Wake Forest group led by Dr. Bitar is looking into this. So what they have done is taken smooth muscle cells and then co-cultured them with gastric cells from the mucosa, and then they bioengineered this model, and they inserted it in the back muscle. And then they showed that this had developed neurons. So this is their model. They take gut biopsy, either from the small bowel or from the appendix, and they bioengineer, they co-culture them together. They create a 3D construct, and then they have shown that this develops a basal tone. And they have implanted this in a rat right now, and they're moving on to a bigger animal, and they want to do a human trial next to show that these constructs are viable. And they have shown that these constructs have a contractile response, whether they are from the appendix or whether they are from the small intestine. And they have also shown that they have a relaxation of these constructs. So they are trying to reconstruct the internal anal sphincter muscle because they feel that having a resting tone is the most important thing. So this is what their construct looks like, and I have to thank them for these slides. And they create these constructs that they feel that they can put in anywhere. They can put it in a colon that's missing a piece or a small intestine that's missing a piece and still have some tone and some progression of peristaltic waves. So this is a very ambitious project, and hopefully we'll see some more results soon. Another group from Michigan is looking at the external anal sphincter. And what they are doing is they're taking biopsy from the oral mucosa and co-constructing it with the latissimus dorsi muscle. And when they do this, they have to create a tone. To do that, they are putting in electrodes, and these electrodes will stimulate this muscle. So this is what it looks like, the latissimus dorsi muscle. They have shown that these constructs do grow together, and then they've shown these constructs, and this one is the native sphincter, the one below, and these are their constructs at 0 and 2 weeks. They are still in the process of implanting them in the rat and trying to figure out how they can measure tone. So do stem cells work? Yes. And there are many studies in the anal fistulas. And the reason I bring this up is just to show you that the reason it works here is because the cell signals are there. There's an active inflammation going on in an anal fistula, and that's why they seem to work. And they also, in Crohn's disease, there's one study out from Australia where they injected it in Crohn's disease and found that 12 out of 15 had a clinical response. Again, the cell signaling is high. Cells will go where they should go because of the chemoattraction. To summarize, I think there are many new innovations in the future. There are many devices as well as cellular therapy which change how we treat fecal incontinence. And stem cells will be an option only if they can be guided to the anal sphincter at a time remote from injury. So if you inject them, they have to live there. They have to do something there. Otherwise, they're just going to die there. And a bioengineered sphincter may be an option with engineering of both internal and external sphincter. So will this therapy be available in the near future? That's the hope. If not stem cells, it may be a cytokine, or it may be a scaffold with cells that can be implanted with a cytokine, or it may be a bioengineered sphincter. The possibilities are vast, but funding is limited. And I request any of you who are on any committees to look at this funding and help us get funding so that we can proceed in the right direction. There is a word of caution, though. The clinical trials, like I said before, injecting stem is easy, but they must have a scientific basis for it. So questions that we should ask is, what do stem cells do when injected in normal tissues or in scar tissue? Do they do anything? What can go wrong, and how do we gauge the success? Thank you.